Hello, sir. Good morning, sir.
Yeah, good morning. Good morning. As part of DNB teaching program, we are having surgical audit MR Bangur, and from last month we started audit of other hospital also because they also want to join. Today, Ruby General Hospital is another DNB institution will present their audit. Dr. Sritamara will present the audit, and Dr. Sumanta De and Dr. Debachan Ghosh will be also there. So Sritamara, you can share your screen and start presenting. You know the format we are presenting.
Yes, sir.
The audit.
Your screen. Is this okay? Is the
Okay.
screen visible?
Wait. Okay. Yeah, yes,
Yeah.
sir. Sharing all. Actually, I'll just share. I just made a little bit change, small.
Okay, sure. Then you.
Oh,
can
then
Yeah.
you share. No.
Yeah.
Okay, you share your screen.
Okay.
Yes. No, something else has come. It's not your audit. Sritama, you are not audible. Oh.
Sir, I probably have some problem with my network. Milinda can share. I'll just share.
Okay, they are sharing. Okay, you start. Sritama, please.
Okay. Good morning, respected faculties and fellow colleagues. Today I'm presenting the audit for General Surgery Department in Ruby General Hospital for the month of February. So, next slide, please. So our total OPD consultation for the month was 542. Admissions in emergency were 6, elective admissions were 87, and total OT in elective was 63 and emergency was 6. Total OT days were 24. Total planned OT hours was 146. Total emergency OT hours was 5. Total numbers of morbidities was 1 and mortalities is 0. So elective admissions total were 87, male 38 and female 49. Emergency admissions were 6, 4 males and 2 females. Total elective operations were 71 and emergency operation were 6. So elective operations 29 were male and 42 females. Emergency operations 6 males and no females. Minor operations, there were 10 minor operations performed, out of which, sorry, I did not change that number. It was 6 males and 4 females, and morbidity is total 1 male. So elective admissions, hepatobiliary and splenic system, laparoscopic cholecystectomy was done for acute and chronic cholecystitis, of which total 11 were male and 20 female. There was 3 cases of subtotal or partial cystectomy, out of which all of them were males. 2 lap converted open cholecystectomy was done, out of which both were males, A lab deroofing of hepatic cyst was done along with cholecystectomy in an elderly female who was having a recurrent case of simple hepatic cyst. Once marsupialization was already done 10 years back, and it recurred again, and it was affecting her general health and causing anorexia and symptom weight loss, and that is why it was done again. And one lab appendectomy was done for a case of acute appendicitis. In GIT and perianal cases, GIT and perianal cases, there was one case of explorative laparotomy with gastrojejunostomy, jejunostomy, and feeding jejunostomy. This was done for a female patient who was having a stricture in the second part of duodenum. So actually, because there was no proven malignancy or there was no proven growth, and she was an elderly female with a lot of comorbidities, so the surgeon decided that we should do a bypass to help her with her enteral feeding and nourishment. Three cases of lateral anal sphincterotomy was done for anal fissure, out of which 2 were males and 1 was female. A laparoscopic anterior resection was done for a case of sigmoid colon growth, which was a female patient. Then there was an elderly female who had a sigmoid and descending colon growth, which was proven to be poorly differentiated adeno-CA, and for her, a Hartmann's procedure was done along with anterior dissection, total mesocolic excision, total mesorectal excision, and an end sigmoid colostomy. This was a female patient. So, and then we had 5 hemorrhoidectomy cases, out of which 4 were females and 1 was a male patient. Incision and drainage was done for perianal perianal abscess, and out of which all of 3 were male patients. Hernia and groin surgery. Hernia and groin surgeries. So for inguinal hernia, we had open medullary intestine repair for 3 cases, laparoscopic TEP repair for 2 cases, laparoscopic TAPP repair for 3 cases, laparoscopic ETEP RS with TAR transversus abdominis release for 1 case, laparoscopic total abdominal retrorectus transabdominal retrorectus muscle repair for 1 case, and for 2 hiatus hernia cases, we had 2 laparoscopic fundoplication where Nissen's fundoplication was performed. Then for 1 right-sided hydrocele cases, we had an eversion of sac, and there was fistulectomy done for fistula in ano cases for 2 male patients. In breast and endocrine department, we had 1 total thyroidectomy done for a papillary thyroid CA patient, female patient, and in miscellaneous group, 2 debridements was done, 1 for a plantar abscess, 1 for a right foot chronic injury, which turned into an abscess, and excision of soft tissue tumor was done, 3 cases, 2 males and 1 female. 2 cases of circumcision was done, which was done electively, and excision of a perianal sinus tract with a fistulectomy was done for a case who had a long-standing perianal sinus tract, and which has turned into a which also had a supralevator, not elevator, sorry, high fistula, high anal fistula. So that was also managed electively. Not electively, it was actually managed in emergency. So in emergency, perianal abscess, incision and drainage was done, discharge in stable condition. Plantar abscess, debridement was done, and next, there was 1 case of morbidity, minor otis. So minor otis, there were 2 cases of debridement as 2 males, incision and drainage for perianal abscess, 3 males, excision of soft tissue tumor, 2 males and 1 female, and circumcision for 2 male patients. And next, the morbidities, we had 1 morbidity in the month of February. So the case is he was a gangrenous cholecystitis case with right lobe hepatic and contiguous right diaphragmatic abscess. The patient was a follow-up case of acute calculous cholecystitis with colloidolithiasis, and there was ERCP done with CVD stone removal in November 2022. After that, patient was discharged, and presently patient was admitted for interval laparoscopic or open cholecystectomy under GA. and relevant investigations pre-op were done prior to surgery. So patient is a known case of hypertension, type 2 diabetes mellitus, ischemic heart disease, and on medications. Laparoscopic converted to open cholecystectomy was done with drainage of right lobe hepatic and subdiaphragmatic abscess under GA on 1st February. So the findings on operation was there was a Waldorf abscess. This was noted in laparoscopy first, that there was a Waldorf abscess noted involving the GB, a colon, duodenum, and inferior surface of liver extending to the right diaphragmatic region. An abscess cavity was entered and pus was drained and sent for culture sensitivity studies. Then we saw that the fundus and the body of gallbladder was completely necrotic and it was forming the anterior wall of the abscess cavity densely adhered to the colon. Then the procedure was converted to open because it was via right subcostal incision, as access was very difficult. After that, colon and duodenum was carefully dissected of the liver along with necrotic gallbladder wall, and residual lumen was packed with multiple calculi, and calculi was removed. After that, lavage was given. Residual GB stump was sutured with continuous vicryl sutures. Next. POD2, till POD2, the patient was managed and like progressing in the right direction, and then on POD2, the drain output increased from the second postoperative day, associated with a little bit of bile staining. It was likely from the GB stump, but there was no clinical evidence of biliary peritonitis or localized bile collection. And POD4, there was a bile leak as measured by drain output started decreasing. And there was a mild wound infection that was noted, and that was treated with daily wound dressing. On POD6, a USG whole abdomen was done. A right subpleural collection was seen over the right lobe of liver surface, for which USG guided aspiration was done, and 25 cc of pus was drained and sent for CS. Patient then also developed decreased urine output with hypotension and clinical features of anasarca and AKI. Serum albumin was 1.4. Then we decided to shift the patient to higher unit. Patient was shifted to HDU, and patient needed inotrope support because the hypotension was not recovered with fluid bolus, and infusion of noradrenaline was given. Parenteral antibiotic therapy was escalated. Patient gradually improved over the next 48 hours with increase of urine output and stabilization of blood pressure, to the extent that inotrope support could be withdrawn, and drain output gradually decreased over the next course of his stay to around 50 to 100 ml around the post-operative day 10. Thereafter, patient was afebrile, asymptomatic, and hemodynamically stable. Patient was passing stool, and there was minimal bile staining in drain output. Then patient was planned for shifting to general ward, but however, the patient was not able to take the financial burden and decided to take a discharge against medical advice. That's all, sir.
Okay, good presentation. I was wondering about the, actually, you have forgot to give the diagnosis of the patient. What you do is, on one column, you put the diagnosis. You mean, go to the first slide. So hepatobiliary and as chronic cholecystitis, 34 cases. Acute cholecystitis, 3 cases. Okay. Then laparotomy, you said duodenal stricture. What was the site for stricture? In which part of the stricture was there?
Sir, it was D2, sir. D1, D2 junction actually. That's where they showed it in the endoscopy.
D1, D2 junction.
Yes.
Any biopsy taken for from endoscopy? No.
Yes, sir. It was taken. There was a small ulcer. The biopsy was taken, but there was no finding of anything. It was just inflammatory.
Yeah, we have done a GJ and KJ. That means you have done a RU GJ. So why do you add a FJ with this?
So the FJ was done because.
Yes.
Sir, sir, the FJ was done to give enteral feeding for a few days. By chance, if there is any problem with the anastomosis, that is why it was given enteral for some enteral feeding to be started a little bit prior, so that after some days the FJ can be removed, and after the patient can take normal food without reflux.
GJ usually does not leak. GJ is the anastomosis which usually does not leak. So we usually don't add a FJ with GJ, particularly RUNY GJ you have done. Okay, fine. So she was started on FG on the next morning?
Sir, no, sir. 3 days. POD 3.
UD3. Okay. So you have good volume of laparoscopic work. And this patient who has got an abscess, I was wondering the patient had a stenting in November. And then
Yes,
the
sir.
surgery was delayed for 3 months. And with this finding intraoperative, how was the patient? How he presented in February, maybe end of January?
But the problem is that patient did not present with any symptoms of any acute form. He had no vitals, any problem in any deranged vitals. Even the problem is he had an USG done from somewhere outside, and there was no mention of any abscess. There was no mention of any inflammation, necrosis of the GB. Everything was found laparoscopically, incidentally. Like we did not have any idea, and the patient had no symptoms.
He might have an acute episode in November when he undergone a chondrocalcithiasis,
Yes, at
stenting.
that time he did.
So that I'm saying that if he has a stenting in November and he has the acute symptoms, why was the patient kept waiting for 3 months? He was in some other place. The stenting was done in some other center.
No, sir. Stenting was done in our center.
Okay. So why was the decision for delaying for 3 months?
Sir, actually, it's not supposed to be 3 months. The patient also came a little bit late, but it was supposed to be done in an interval only.
Okay. The decision was good that it was converted and the subtotal collection was done. Now the bile, you did not remove the drain. He left the hospital with the drain on. He left the hospital with the drain in situ.
Yes, sir. He left the hospital with the drain.
Okay. Hemorrhectomy is all open hemorrhectomy or stapler hemorrhapexy?
No, sir. All open cases.
All of them. Milligan Morgan. Yeah, any comment, Dr. Sumanto De?
Good morning, sir. Hello.
Yeah, yes,
Hello,
Dr.
am I audible?
Sumanto. Yes,
Hello.
good presentation, good number of cases.
Good morning, sir.
Yeah.
Thank you, sir. Actually, these are all combined cases of me and Dr. Devachan, sir, and Dr. Gota Kurata. So, like, we get a good number of planned cases, but naturally, the number of emergency cases are low in our hospital. Still, we get in 2 or 3 cases in a week. Emergency. So for the PG, it's a big place compared to the other medical colleges and hospitals. But to combine all the types of cases
Even
and
medical college has
try to
now
do it
less number of emergency
laparoscopically.
cases. Even medical college has less number of emergency cases because most of the appendix is done at peripheral setup. The appendix does not reach Kolkata. Most of the medical college now has very few appendix in the month.
Yes, sir.
Even in MR Bangalore also we
Even
have
the
less number of
number of
emergency cases.
yes,
Okay,
sir.
thank you,
The
Sritama.
number of
Good presentation. Okay, you can keep on presenting, no problem. You can accommodate other hospitals. So this is a good way of reviewing cases, and then if a morbidity and mortality, you can always discuss why the mortality happened, what could have been done to avert the mortality, and what is the likely cause of mortality. So we can always discuss the morbidity and mortality. Okay, so now I pass on to the audit presentation from MR Bangalore Hospital, Unit 1 of Dr. Kuntal Chakraborty and Dr. Kaur will be presented by Mehul Patel. Oh, sorry, Prashanjit Basu. Prashanjit, please come.
Good morning, our respected faculty members. I am Dr. Prashanjit Basu, and I am going to present surgical audit for the month of February 2022 for Unit 1. We have total OPD days 8 and total admission day 9. Total OPD patient 1030, in which we old 412 and new 618. Total number of elective OT days are 8. Total time in OT, table 1 lab 28 hours and 30 minutes, and table 2 open we have 39 hours and 30 minutes. Total number of minor OT days 9, and total number of mortality includes 1 and morbidity 1. Audit for February 2023. Elective admission we have 26, 17 male, 19 female. Emergency admission 26, 10 male and 16 female. Elective operation we did 27, in which 12 male and 15 female. Emergency operation 12, in which 7 male and 5 female. Mortality 1 and morbidity 1. Hepatobiliary and pancreatic spleen exercise in chronic calculus cholecystitis. Lab cholecystectomy we did 9 cases. Open cholecystectomy we did 1 case.
Next.
In GI and perianal cases, fistula in we did fistulectomy 1 case, recurrent open appendicectomy 2 case, and recurrent lap appendicectomy 1 case. In hernia and groin surgery for umbilical hernia with lap hernioplasty 1 case, incisional and ventral hernia with mesh hernioplasty at retrorectus plane 1 case, and inguinal hernia Lichtenstein tension free mesh hernioplasty 7 case, and inguinal hernia herniorrhaphy we did 2 cases. Total we did by mistake 11 cases. Miscellaneous circumcision 2 and foreign body removal in left lower limb under C arm we did 1 case. And in emergency case obstructed inguinal hernia mesh hernioplasty we did 1 case, and acute open appendicectomy 1 case. Perianal abscess we did IND under TIVA for 4 cases, and diabetic foot also we did diabetic foot debridement under LA for 6 cases. Total 12 cases. For minor operation we did excision of hemangioma by mistake. Original presentation excision of pyogenic granuloma 6 cases, lipoma excision 7 cases, and JADAX procedure we did for paranoia 5 cases, and sebaceous cyst excision 12 cases, and excision of corn we did 4 cases. By mistake it's 1.
Next.
In morbidity, we have 1 case and mortality 1 case. In morbidity, a 45-year female patient who is a post-op case of open cholecystectomy on POD3 develops seroma, which is managed conservatively by dressing and swab sent for culture center, but it's come out to negative. Mortality of 52-year male who presented with subdural hemorrhage, was presented with unstable vital and gasping breathing, is admitted. Initial resuscitation was done. We secured the airway with intubation and put the patient into tube. Patient developed cardiac arrest within 2 hours of admission. We tries to resuscitate, but it fails and patient is succumbs to death.
So it was basically subdural hemorrhage.
Subdural.
We came with a CT scan.
Yes, sir. CT proven.
One is the interval between the injury and the arrival here.
Sir, 1 hour.
From injury to arrival.
Yes.
What is it? We don't have neurosurgical facility.
Yes.
But this patient died within 2 hours. Difficult. But patient having a subdural hematoma and patient is having.
Sir, he has a history of hypertension and CVA, old CVA.
Old CVA.
Yes, sir.
It was not intracerebral hemorrhage.
No, but it's acute and chronic case. It's presented acutely, but it has he has a history of old CVA.
So
But on that day, he
patient could not be referred.
presented no,
On
sir.
arrival, patient could not be referred.
No, sir.
The patient was directly at
Emergency point is directly admitted.
Next, you see, seeing a subdural hemorrhage is no point admitting in MR Bangalore hospital. because you're not going to do the surgery, and surgery is the only treatment for this patient.
So emergency decompression was required
ICU bed
because
is
the
also
patient
not
was
available.
unstable. They decided to, without consulting with the department, they decided to directly admit. And the patient was shifted to the ward. ICU bed was not admitted, so they had to manage the patient, and what the intubation, resuscitation, everything was done by them in the ward cell. They even arranged for the noradrenaline.
So we don't have neurosurgical facility, that is the problem. Okay. Okay, next. Next will be a presentation of audit of Unit 2 General Surgery at MR Hospital, presented by Dr. Mehul Patel, who is a first year junior resident.
Good morning, everyone. I'm Dr. Mehul Patel. I'll be presenting surgical audit for Feb 2023 for Unit 2 General Surgery, MRBH. Total number of OPD days were 8. Total admission days were 9. Total OPD patients were 1,023. Total number of elective OT days were 8. Total time in OT in lab was 33 hours 15 minutes and open was 30 hours 40 minutes. Total number of minor OT days were 8. Time in minor OT was 8 hours 40 minutes. Total number of mortalities 2. Total number of morbidities 0. Total 44 elective admissions were done. 31 emergency admissions were done. Out of that, 40 elective operations were done. 17 male, 23 female. 23 emergency operations were done, 10 male and 13 female. Minor operations 31, 15 male and 16 female. Mortality 2 and morbidity 0. In hepatobiliary and pancreatic and 11 laparoscopic cholecystectomy was done for chronic calculous cholecystitis. 3 open cholecystectomy was done for chronic calculous cholecystitis. 1 extended cholecystectomy was done for gallbladder with fundal mass. 1 exploration, 1 excision of sinus tract was done for a case of post-cholecystectomy sinus tract formation. In gastrointestinal and perianal surgeries, 1 lateral anal internal sphincterectomy was done for anal fissure. 1 fistulectomy was done for fistula in ano. 2 hemorrhoidectomy was done for internal hemorrhoids. 1 Thier's operation was done for a rectal prolapse. 1 open appendectomy was done for appendicitis, and 1 diagnostic lab with appendectomy and salpingectomy was done for acute appendicitis with salpingitis. 3 Lichtenstein mesh hernioplasty was done for a case of unilateral inguinal hernia. 1 herniorrhaphy for a unilateral inguinal hernia. 2 reef stopper repair with abdominoplasty was done for multiple ventral hernia. 2 anatomical repair was done for umbilical hernia. 1 open mesh repair was done for incisional hernia. 3 jobless procedure was done for hydrocele, and 3 circumcision was done for phimosis. In breast and endocrine surgeries, for unilateral breast fibroadenoma, 2 cases of unilateral breast fibroadenoma, excision was done. In emergency operations, for uterine and bowel perforation, 2 cases were there. Exploratory laparotomy with primary repair was done. 2 cases of foot ulcer department was done. 1 incision drainage was done for gluteal abscess. 2 incision and drainage was done for submandibular abscess. 3 incision and drainage were done for perianal abscess. 1 incision and drainage was done for supraclavicular abscess, and 1 incision drainage was done for breast abscess. 1 case of acute constant pancreatitis was managed conservatively. A case of acute alcoholic pancreatitis was also managed conservatively. A case of acute calculous cholecystitis was also managed conservatively. 2 acute appendicitis, for that emergency appendectomy was done. 3 cases of subacute intestinal obstruction, conservative management was done. 2 cases of foot cellulitis, conservative management was done. And for diabetic foot ulcer, dressing and debridement was done. Debridement dressing was done. In minor operations, sebaceous, 9 cases of sebaceous.
24 minor. Next.
24 minor operations. 1 chest drain incision was done. 2 mortalities. Mortality 1, 82-year-old male presented in the emergency with features of intestinal obstruction and septic shock with history of 10 days and having multiple such episodes since 2017. On presentation, the BP was 96/67 mmHg, heart rate 120 per minute, and SpO2 80%, and labored breathing. Urine output was negligible. Initial resuscitation was done, but the patient was a non-responder. ABG showed severe metabolic acidosis. The patient was shifted to ICU and was started with NORAD support and ventilated. On D1, the patient was started on higher antibiotics, and in the evening, the patient developed cardiac arrest and was succumbed to death. Mortality 2, a 45-year-old male was admitted for elective cholecystectomy. Preoperative USG was done, which showed GB fundal mass. CT scan and MRCP was done, which also gave the query for fundal mass. So extended cholecystectomy was done. On POD0, the ABG was done, which showed severe metabolic acidosis, BP 100/62, heart rate 102, and SpO2 85. Sodium bicarbonate and oxygen therapy along with nebulization with duvalin and budecort was given. The patient didn't respond to the treatment and succumbed to death after 4 hours. Thank you.
What is the second case of death? There was a fundal mass in CT scan.
Yes.
How was CA19-9?
So that was normal.
Normal. He did not do a pre-op FNA. Was a pre-op FNA done?
No,
Not recommended also, agreed. But how was the intraoperative phase? Was there any excess bleeding or patient has any other problem? Because a young patient, 45 years, following external patient should not die.
So there was.
What is the technical problem? Intraoperative? Was there bleeding?
There was bleeding.
Some bleeding.
Because we don't have advanced energy sources. No? See, difficult to carry out a external colostomy, just a simple unipolar diathermy, difficult. So there is excess bleeding intraoperatively, and patient has given blood transfusion.
Yes, a patient was given blood transfusion.
2 units of blood.
Okay. Go back to your previous slide. You see fibroadenoma. What is the patient profile? Because you see, most of the fibroadenomas does not need surgery. Particularly young patient with fibroadenomas less than 2 centimeter, they does not need surgery. How was these two patients who required excision?
35, 40 years, middle age.
Middle age. Oh. Size of the fibroadenoma?
So around 4 to 5, 4 into 5.
Or is almost a giant fibroadenoma. Okay, so a young patient, you always keep in mind that young patient with fibroadenoma does not need excision. Most of the patient, it goes spontaneous regression, or you can give some therapy, centcomen or danazole. Okay. Diptaman has come? No, on the way.
Dr. Deeptaman, are you there online?
He joined.
Yes.
Okay.
Slides are here. Okay, Diptaman, slides being shared, you just presenting. So you say you need
Yes, sir.
3 just presentation by Dr. Diptaman Nandi.
Good morning, respected teachers and my dear colleagues. I am Dr. Diptaman Nandi. I am going to present the surgical audit for Unit 3 General Surgery. Sir, I am audible? Sir, I am audible? Now, regarding the OPD summary, total OPD days 8, total admission days 10, total OPD patients was 1011. OT summary related, total number of elective OT days were 8, total time in OT included the lab 27 hours 15 minutes and open OT 32 hours 25 minutes. And total number of minor OT days were 8, time in minor OT 10 hours 15 minutes, time in emergency OT 2 hours. And number of mortality nil. Now, some detailing regarding the audit. Elective admission cases were 41, among which 17 were female and 24 male. Emergency admission cases 9, including 3 male and 6 female. Elective operation was 33, including 18 female and 15 male. Emergency operation 2, injury 2 male. Minor operations 43. Mortality nil and morbidity 2. Regarding hepatobiliary and pancreatic splenic surgeries, chronic calculus cholecystitis cases were total 12, in which male 10 and female 10 and male 2, which were undergone laparoscopic cholecystectomy. Chronic calculus cholecystitis cases underwent open cholecystectomy. Actually, these two cases were initially tried with laparoscopic, but they were converted to open cholecystectomy cases. There was a case of cholecystectomy which underwent hepatico-jejunostomy. These were two cases. And one is male and one is female.
Diptaman, just go back.
Yes, sir.
This cholecystectomy treatment is not ruined by NJ. Cholecystectomy patient has cholecystitis with cholecystectomy. The surgery done was cholecystectomy, cholecystectomy, and cholecystomy. It was not a hepatico-jejunostomy. I don't remember that you have done jejunal lobe being brought up. It was hepatico-jejunostomy, duodenostomy, not jejunostomy. Okay, give the details. It was not an isolated case of cholecystectomy. This patient has gallstone. We did cholecystectomy, cholecystectomy, and a hepatico-duodenostomy, or you can say cholecystomy.
Okay, sir.
Keep the record correctly.
Regarding gastrointestinal and perianal cases, there was a case of subacute intestinal obstruction which undergone exploratory laparotomy with additional lysis. This was a female patient. There was a case of perianal fistula, underwent fistulectomy, and there was a case of appendicular fistula which underwent laparoscopic appendicectomy and fistulectomy. Regarding hernia and groin surgery, there was a case of umbilical hernia which undergone IPOM class. There was a short frenulum cases which underwent frenulectomy. Incisional hernia cases were one ventral hernia which underwent mesh herniaplasty. Then there was a case of tape herniaplasty. There was a male patient. There was total immunotal hernia cases 5 which underwent Liechtenstein mesh herniaplasty. There was a case of carcinoma penis which underwent partial penectomy. There was a case of hydrocele underwent eversion of sac, and there was one case of phimosis underwent circumcision. And there was a case of varicose veins, which this was a female patient which undergone Trendelenburg operation, and there was also a female case of
Diptaman.
Yes, sir.
Diptaman, it's not only Trendelenburg. Diptaman, it's not only Trendelenburg. Trendelenburg is one part of the operation. Flash ligation of SFJ. Apart from this, we have done stripping of the upper segment of the vein. We have done few perforal ligation. So Trendelenburg is not the only operation done. Is one of the part of the operation is Trendelenburg plus stripping of the gates appendage up to the upper knee and multiple perforal ligation. You see, give a complete description.
Yes, sir. Then there was a case of left subscapular cystic swelling which underwent excision. Regarding emergency operation, there was a case of head injury which underwent repairing was done. And
You don't repair for head injury. Keep in mind, Vittaman, it's a scalp injury. Head injury is something else. If you repair, it's a scalp injury. It's not head injury. Head injury implies some other either injury to the skull or some intracranial hemorrhage. Okay, so it's a scalp injury. You have done a repair. Okay.
Okay, sir.
Right, correctly.
Then there was a case of left leg abscess in the calf muscle, which was done IND. Regarding the next part of emergency admissions, there was 3 cases of acute calculus cholecystitis, which underwent conservative management. Then there was 2 cases of food cellulitis with T2TM and HTM, which also underwent conservative management. And there was also 2 cases of diabetic foot ulcer, which underwent debridement and dressing. Now, these are some list of minor operations and emergency interventions done in our EROT. This is which were 3 cases, 1 excision of sebaceous cyst, 18 cases, lipoma excision 5 cases, papillomatous growth excision 3 cases, incision and drainage of abscesses 14 cases, foreign body exploration 2 cases, and there are altogether 43 cases in which female was 17 and male was 26. Regarding morbidity and mortality, mortality was nil, but there are 2 morbidity cases. Morbidity 1, this was a 40 years old male patient was admitted for reversal of Hartmann's procedure. Actually, this patient was admitted in the end of January 23. POD 1 was uneventful. Since POD 2, he started having slight distension of abdomen and complaint of pain abdomen. He was continued on NPM and IV antibiotics and fluids. In POD 3, he started having discharge from the OT site, which continued for the coming day in spite of daily dressings and other supportive management. So it was decided for re-exploration, and ileostomy was done on day 7 from the day from reversal of Hartmann's procedure. After this, the patient was given supportive care and regular wound dressing, which continued for next 7 days, and after which the patient improved and was discharged. And the morbidity 2, this is a case of 16-year-old boy admitted with pain abdomen. CECT whole abdomen indicated only mild ascites. USG whole abdomen gave a cystic swell in the lower abdomen. On clinical examination, there was a swell around bladder. Patient having operational fever with increasing total count. Patient was catheterized, given injection meropenem and other supportive care. He has been admitted nearly for 2 weeks. He is still admitted in our ward, but his condition is much improved now from the previous scenario. Total count is nearly normal. Fever subsided, pain abdomen also diminished. The swell is also not palpable now. We are planning to discharge him very soon.
Diptaman, why do you take this case to morbidity? This was a patient who was diagnosed to have likely to appendicular abscess with a pelvic abscess. So his whole treatment was conservative, and this hypogastric mass which was there was likely to be also in a distended bladder, which subsided with catheterization. Okay. And then he responded to meropenem and other antibiotics. It's not a morbidity. This is a course of a patient who are having appendicular abscess. And go back to the first morbidity. You see, you have not really mentioned. You see, this is a patient who underwent, he was admitted for reversal, but he underwent reversal. On which day? And POD 1 or POD 2 started distension, and then finally he was having febrile discharge. So that is the time he decided that yes, we should go in.
So the patient was admitted for electively planned for reversal. He had undergone for Hartmann's procedure in 2020 for interstitial obstruction, which was later found out to be C. sigma adenosine. So this patient was there in the ward for around 5 days, where we checked the distal segment, and then we checked the patency, then we went for a reversal. By the evening of day 3, he had distension.
The interpreting was also a little difficult.
Yes.
There was a lot of adhesions, and after mobilization, it was possible to do a anastomosis, but it was very difficult to mobilize the guard segment. So he started leaking from the second day. He has increasing pulse. He has mild fever. Count was also increasing. And then once he finally has got a febrile discharge, we decided to go in and do a diversion. The first go, we have not done a diversion. We did not do a diversion because it was a high up anastomosis, and already he had a stoma done. So after reversal, he did not attempt for a ileostomy to be done, but we taken a chance that it might go on, but he did not go on with smooth post-op recovery. There is a leakage. So he did a personal diversion, and he continued to have some febrile discharge because we have not brought out the anastomotic site. There's partial dehiscence, so we have not disturbed the anastomotic site. That was kept as such. So there was some discharge from the drain for the few days, and then by 7 days it was almost negligible, and he was discharged. So now he has a status ileostomy, and the next plan would be to see the status of the anastomotic site, and then you can decide about closure of ileostomy.
After the diverging ileostomy was done, sir, the fecal discharge also reduced, and he was discharged taking full oral diets.
Yeah.
So the leakage after that was subsided. And we discharged after doing a secondary closure of the.
So if any DNB student from other hospitals are there, you can think of presenting your audit. Maybe Barashat Medical College now, Jagannath Gupta, Asansol. If you want to present, you can let us know. We can accommodate other hospitals. We will do the audit of MR Bangur and another hospital outside Bangur. Okay, we can accommodate 2 hospitals for audit presentation. Okay. Any comment from anyone? Okay, thank you.